And I welcome Dr. Kanhu for the next talk, that is the target volume delineation in soft tissue sarcoma. Dr. Kanhu needs no much introduction because everyone is aware of his contribution to the educative endeavors for the radiation oncology fraternity. And I hand over to Dr. Kanhu to carry on with the next topic. That's target for delineation for soft tissue sarcoma.
So good evening all, and good evening to all my teachers who in the dais, and just I will start the target delineation. Am I audible?
Yes, Dr. Kanhu, go ahead.
So thank you my all teachers giving the opportunity. So I will talk about target delineation in soft tissue sarcoma. So in the target delineation what are the brainstorming work? One is the positioning, immobilization, scar should be included or not, edema should be included or not, what is the margin for the retroperitoneal sarcomas, what is the margin for extremity sarcomas, what is the lymphatic drainage corridor. So before starting contouring, you have to remember ETS. What is ETS? Examination findings, pre-op, post-op, and what is the pair of findings? Just to go through it, how it is attached to deep fossa, how it is a subcutaneous infiltration, what is the skin infiltration, where is the biopsy scar, everything you have to go here. What is the treatment history? Whether radiation is given pre-op or chemo is given, no chemo is given, surgery. Please go through the treatment history. Then see the imaging. MRI is a must. We see the imaging. What is the quality of the tumor? What is the edema? What is the longitudinal spread? What is the bone invasion? What is the joint cavity invasion? Everything you just note down the positive findings. Operative notes is
Hello, Kanhu?
Surgical pathology, you have to see what are the grade, size of the lesion, and how is the neck. If you are given chemo or radiation before, what is the necrosis path? Everything you have to. So before your start bottom, you have to find out these ETS findings. Simulation, immobilization in radiotherapy is a very important thing to daily stabilization. So find out which is the best comfortable position for the extremities. That is the very movable thing. So we have to that is comfortable to the technician, comfortable to the radiation oncologist, comfortable to the patient. So comfortable to the patient is very important. This is called 3-point technique. So when you are stabilizing the patient for the radiation things, we are putting CT lasers, CT markers or fiduciary markers at 1 point. So we avoid, apart from that fiduciary markers, we have 3-point markers. So 3-point markers means in extremities, use just 1 point here, do tattoo on the thigh, tattoo in the leg, and tattoo in the foot. If you are doing in the lower extremity, same thing you have to do in this all things in the upper extremity. So that will allow your more accurate alignment. So 3-point technique is more useful in the soft tissue sarcoma. So if you are treating the thigh for the frog leg is the, so why we should go for the frog leg? You have to separate out the thigh and decrease the dose to the gonads, as well as the separate out the dose to the upper part, other part of the other leg. So this is the called, when you are treating the thigh, upper thigh, better go for the frog leg. If it is going for the lower extremity leg, so you can go for the simple supine position and give some separation, so that it will allow to give two separations, so that will help you to dose to the other part of the body. Otherwise, you can keep up and down in this area. So put one leg in the up, one in the down, so that it will be also easier to decrease the dose to the other part of the leg. Another thing you can, if you are treating the other part of, just if you see, this is the one leg and then the other leg. So this is the also, you can see one is the up and down, so that you can spare load spill to the other part of the other leg. Same thing, you can use foot rests. So it will be help to you to put in the legs in a there are knee rest, foot rest, leg rest, lots of things are immobilization devices are available, you can utilize. And avoid the chest. So to treat the soft tissue sarcoma of the upper part of the upper extremity, you have to avoid the radiation to the chest wall or lung. So you can for the anything you have from the arm, forearm, and palm, you can go for this position. It is the with some sort. So you have to go for the 3 marking system and use some thermoplastic mask or vehicle. So if you want to supine position, if you want to treat, avoid chest, you just separate out the things from the abdomen or chest by separating the arm. Same, if you want to treat the arm, you can put upward and external rotated and abducted. Same thing, if you are treating the arm again in this position, you can treat also. And if you are treating the buttock, always take in the prone position, and that will be fine to decrease the dose to the anterior-abdominal structures. And prone is the best best thing we can go for the buttock areas. So what is the thing? Surgery alone is a stage 1 with 1 centimeter with intact facial plane, more than 1 centimeter. Consider radiation for the close and positive margin, but after optimal re-excision. If you repeated re-excision, positive margin coming, then you can go for the radiation. In stage 2, stage 3, surgery plus RT, pre-op and post-op, chemo for large and deep high-grade tumors. Stage 4, you can go for the oligometastatic diseases. You can go for the primary site as well as the metastatic sites. What dose should be you give? Dose should be CTB should be tumor bed, edema, and scar. 250 gray, and give around 66 gray to the R0, 68 gray to 62 to 68 gray R1, 70 to 76 gray R2. If pre-op setting if you are going, then you go for 50 gray only, 16 to 20 gray depending on the R1 and R2 resection. If you are not resectable, you can go up to extreme 75 gray depending upon your OAR acceptability. So so this is the thing, and no elective nodal irradiation is required unless it is involved or surgically dissection done and there is extranodal extension is there, you go for radiation. So same thing here, if you are going for brachytherapy, 45 gray LDR or 36 gray in 10 fractions, positive margin, you can go for the boost after that 50 gray EBRT, and IORT you can go for the 10 to 16 gray intraoperative radiotherapy followed by 50 gray to external RT. So what are the equipment used for the immobilization? You can use thermoplastic, marks, vacuum bag, bolus, foot rest, ankle support, hand grips, and other. Application of custom built or manufacturer based you can use. Patient set of tolerances, either palliative treatment or radical treatment, you have to see. Existence protocol for the STS treatment, your institutional protocol you can find out. KV, MV, cone beaming, severities you regularly use daily, or you can do daily, fast reflection, or weekly, or according to your institutional protocol. Either you can go for IMRT, you can go for 3D CRT, you can go for VMAT. See the loaded spill with IMRT and VMAT, that may be a problematic. Treatment times maybe depends upon the 3D CRT and IMRT VMAT. Application of surgical clips encouraged, and discuss with the surgeon to put surgical clips during treatment. Pre-op if you see the pre-op party, post-op party, pre-op party is a smaller volume, low radiation dose, decreased tumor seedling at surgery, improves resectability, less tissue hypoxia before surgery. Advantage of the post-op party, no surgical delay, pathological staging, margin assessment possible, no RT related healing problems. Disadvantage in the pre-op setting is the delay in surgery, increased wound complication, ISC may be altered or sometimes problematic, boost in patients if there is a margin positive, again you have to give radiation. Disadvantage of the post-op party, irradiate a larger volume, higher RT dose required, chances of fibrosis edema is more and irreversible. Hypoxic involvement after surgery because of the blood lack of blood supply. So these are the very good things you have to remember. Fuse CT and MR in the same thing, same position. If you are, suppose you are going to treat the buttock, so ask those do MRI in the prone position, do the proper fusion, and same position MRI is mandatory if you are going for the MRI CT fusion. Margin can be shortened depending upon the bone, joint, fascia, and boundaries compartment. Bolus of the scars and drain sites, first 50 gray, controversial. Typically, don't do elective nodal irradiation unless it is positive or dissected with extracapsular extension. Upper limb and thigh best treated with frog leg position. Buttock and post thigh best treated in positionation. Biceps treated with abducted, internally rotated. But it is often necessary to access multiple positioning and during simulation. There is a very important thing to avoid some things, like if you are going for more than 50 gray, weight bearing bones like femur, you should not treat the whole circumference of the femur. And anterior part of the tibia, that is a scene of tibia, that is less vascular. You have to very careful. Avoid treating anus, perineum, urogenital tract. Avoid treating lungs. Avoid dose maximum for the surgical scars. Don't go for the DMAX at surgical scars. Heel, ball, and lateral edge of the toe should be properly spared if possible. And we should not go for the avoidance structure. These are called avoidance structures. So what you have to do? More than 20 gray can prematurely close epiphysis. So if you are contour the epiphysis, contour and put the less than 20 gray. Bone marrow, try to decrease the bone marrow if possible by less than 40 gray. If there is a bone cortex involved and going more than 50 gray, the high chance of fracture, and more than 40 gray causes fibrotic constriction. Brachytherapy, as you know, single plane, multiplane plane, you can go intra radiotherapy, brachytherapy, either a boost or a radical manner. Choice is yours. These are the handling wires, various liver, stomach, kidney, spinal cord, large bowel, rectum, testicles, and femoral head. These are the various, in grossly, these are you can available online or according to institution protocol. Remember, maximum dose to femoral is less than 50 gray or B40/40. I will come later. So what should are the evidence structures? One is the heel, one is the lungs, one is the joint cavity, one is the anal and perineal genital area, another anterior tibial spine, scene of tibia. Apart from that, you have to go for a lymphatic corridor. Suppose sometimes you are going to treat the part of this sarcoma treating. You are starting treating with VMAT or IMRT techniques. So part of the things you have to contour specifically. So this is called a lymphatic corridor, around 1 to 2 centimeter round straight structure, elongated structure. You have to, along your PTV, you have to contour. So this called lymphatic corridor. So if you treat whole the skin, there will be a high chance of lymphatic drainage problem. So there will be ET problems. So you have to call, it is called lymphatic corridor. Remember, you 1 to 2 centimeter circle around from the along all area of the PTV margin, below 5 centimeter and above 5 centimeter, contour, and try to keep this dose minimum alara or at least less than 20 gray, so that the lymphatic drainage will be possible. There will be less chance of post treatment lymphatic edema. So this is you have to contour the bone also, you have to contour the joint cavity, you have to contour the lymphatic corridor. So there is a good article in our Red Journal published in 2009. What is the femur dose should be? So if there is a pathological fracture and if there is a periosteal stripping, keep the mean dose less than 37 gray, B40 less than 64%, and maximum dose 59 gray. Limit the slices of 50 gray encompassing the entire femur. keep the V50 and 50%, less than 50% in joint cavities. So 50 gray isodose line is very important. Let's see, if there is a long bone fracture is high chance if you are treating whole femur circumference. If there is a stripping of the bone during bone exposure, high chance of fracture. If there is a periosteum stripped, high chance of fracture. If there is a given neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy, there is a high chance of fracture. So this is the very important thing you have to keep in remember. You don't treat total circumference of the femur. Which structure should be editable? One is called abode. You can remember air, bone, organs in, like if you are treating retroperitoneal sarcomas, you can see organs like liver, lungs, kidney. You can think if your muscle, your soft tissue sarcoma is involved above the deep fossa, but don't go to deep fossa, or at least 0.5 centimeter you can go inside. External skin should be avoided unless it is involved. Joint cavity, again, it is a very important thing. You have to avoid the nearby joint. You have to contour and keep the V50 less than 50% to preserve the synovial function. Avoidance structures, again, male gonads and female gonads are very important. So this is the thing we what we do. We if we are treating the thigh and everything, we just put the drag the penile and scrotum structures upwards, and we strap like this regularly during treatment, and we try to decrease the gonadal doses. Apart from that, if patient is affordable, patient is interested, we have to do the familial counseling. You go for the specimen preservation or oocyte preservation. Apart from that, if you are treating the pelvic area or thigh area, if there is a contour the ovarian structures, and do oophoropexy and displace the ovary or fix the ovary in the upper part of lower part of the abdomen rather in the pelvis. So this oophoropexy, semen preservation, oocyte preservation is desirable if patient is interested. If you are going to do the things, study all these things, these are the various articles for the contouring guidelines. You can go to the e-contour also. You can go for the retroperitoneal sarcoma guidelines. These are the for the how to decrease the fractures and how to decrease the low length, volume, and relationship and bone fracture. These are the various good articles. So let's do the practicality. Suppose it is a pre-op sitting, you go for the GTV. This is your contour. This is the MRI and CT contour. Then give radial 1.5 centimeter margin and 4 centimeter longitudinal. 4 centimeter longitudinal, 1.5 centimeter radial. And any lesion, any margin is going to the bone, you please edit it. Suppose there is a edema, after giving 4 centimeter also, it is not covering, you should cover the edema, increase your CTV. But sometimes edema is so long, so any head ray you find out at the clinical settings, you find out how much edema we should include, and you can include the edema. After that, you go for the PTVs 1 centimeter or daily IJT you can do. You can decrease the PTV according to the institutional protocol. In post-op settings, another thing comes into your mind is the scar. Controversy about the scar and drainage area. But in this guideline says you contour the scar. If your CTV is not and give 2 centimeter margin around the scar. Treat the scar. If skin is not involved, still treat scar till 50 gray, and in boost phase it is not needed. So same GTV post-op bed, you take help of the clips, MRI, fuse it, then give 4 centimeter up and down, 1.5 centimeter radially, then PTV 1 centimeter or depending upon your institutional protocol. When you are going to boost, just decrease the longitudinal length around 2 centimeter and 1.5 centimeter radially, but 2 centimeter less comparing to the adjuvant setting. Boost will be less than 2. Longitudinal treatment length should be 4 centimeter and boost length will be 2 centimeter margin. So I am going to explain a patient who came to me at 27-year unmarried male, swelling and posterior lateral aspect of thigh 2 months is the left side, wide local extent on outside. So non-contrast MRI pelvis he did T1, T2, 5.3, 7.9 and 8.9 is the mass size, mass arising from gluteus maximus, crossing the facial plane to subcutaneous tissue, solid cystic lesion, fluid level is in the T2, septate, adjacent edema, suggestive of malignant etiology. So this is the thing we can see. This is the lesion here. This is the gluteus maximus muscle, and you can see this is the lesion here. So they did non-oncologist, they did wide local excision. The lesion came to 6 centimeter, 5 centimeter, 4 centimeter, malignant peripheral nerve system humor. No comment on margin, no other comments. So we did, these are the various ISC markers. You can go through it, which tumor looks, which marker positive. So we did for this, we did CD99 positive, BCL2 positive, and TLE1 positive. And this gives rise to synovial sarcoma. TLE1 positive is the gold standard and came as a synovial sarcoma. So final diagnosis, synovial sarcoma, left lateral thigh, PT2, complete excision. But because it was done by oncosurgeon, so we went for the wide local excision of the residual tumor, no residual tumor after in the pathology. So after tumor was discussed on oncosurgeon, the patient and board decided to plan for adjuvant radiotherapy, and patient was explained about the complications outcomes of the procedure. So we planned for 50 gray in the first fraction, 16 gray because R0 resection, boost is a 16 gray, phase 1 is the 50 gray. After discussion with the radiation tumor board, planned for the adjuvant radiation. Patient we counseled about the gonadal dose, planned for sperm banking as unmarried, chances of recurrence, avascular necrosis of femoral head, and skin and subcutaneous fibrosis. These main things we discussed with the patient. Simulation we did supine, hands up, back lock, leg straight, a gonads displaced manually, upward fixed with the tap. So we take any contrast-CT 5 mm from umbilicus to knee joint, scar marked by copper wire rather than lead wire, because lead wire causes more artifact. You plan for thin copper wire, transfer to the contouring station. So you did image fusion pre-op MR and pre-op CT. We contoured the scar, contoured the surgical clips, contoured the surgical bed. MRI, our GT was MRI GTV plus edema. So we made a Boolean about clip, cavity, GTV, edema, all together we made a GTV, that virtual GTV rather than a real GTV. Then we given CTV 4 centimeter superior and inferior, 1.5 centimeter radial, and 2 centimeter of scar margin. We edited these things from femoral head, uninvolved subcutaneous plane, and given the P2 1 centimeter margin. So we followed this guideline. What we did, so this is the various two protocols we can follow, RTUG 0630 and PMH protocol. So according to this protocol, I am not going to the details. So what do we do in GTV, MRI and CT, fusion, post-op bed, clips, will be reconstructed GTV. CTV, proximal and distal 4 centimeter, radial 1.5, cover the T2 edema, exclude skin, subcutaneous tissue and bone, confined to muscle and compartment. If 4 centimeter expansion reconstructed surgical volume is shorter than the surgical, the elective should be, if your scar will be more, but CTV 4 centimeter may be less. So you have to include, enlarge your CTV to include the scar. Surgical disturbed tissue, any scars, density included within 1 to 2 centimeter margin of expansion. So it is a controversy to include the drainage site or not. So drainage site, if it is confined with the CTV area, please treat. If it not outside, don't treat. So CTV 1 centimeter, CTV 60 is the, as I told, boost is only 2 centimeter longitudinal, and PTV boost is the 1 centimeter. So this is the we have taken in the patient in the supine position. This is the scar mark area. Then we put the copper wire here. We put the copper wire in this direction. Then patient in the supine position, hands up. Then we contour this is the clips. We can see the clips. Then this is the scar marking. We did the scar contouring. Then we given the margin to scar around 2 centimeter around it. Then this is the post-op cavity including scar. Then we given CTV longitudinal 4 centimeter and circumferential 1.5 centimeter. This is the thing we did, but we edited the red one is the edited one. So we included slightly extra edema, as well as though you deducted the cavity CTV from the bone. Then this is the things what we did. Gonad we strapped in the upper part of the abdomen, lower part of the abdomen, and the femoral head, rectum, gonads. We did the contouring. Then strapped the gonads strapped to opposite side and above in the abdomen, and we planned with a arc therapy and 3D CRT. So we thought we'll go for 3D CRT or arc. In comparison, we saw that rectum is getting more with VMAT, gonads getting more in VMAT and IMRT. Same thing, left femur is getting more with 64 gray, but less only. And bladder dose is more with VMAT plan, and 3D CRT plan is less. But PTV coverage is almost equal in both. Slightly not 95% or 100% coverage, because it is near the skin area. So we don't use bolus. This is the boost planning, so almost similar. So this is the 3D CRT volume, this is the VMAT volume. So if you see, loaded spills are mostly in the abdomen. So we treated 3D CRT volume. If it's 70% spill, if you see, 3D CRT volume more spill around this area, but IMRT spill is inside the abdomen. But at last, this is the coverage of 3D CRT and IMRT. Comparing to the VMAT, IMRT might be smaller coverage, little smaller coverage, and this is the boost coverage, slightly less comparing to the VMAT. But we accepted 3D CRT plan looking better with respect to gonads. Though small variation in better dose profile with femur in the VMAT. VMAT is more spillage inside the rectum, bladder, and bowel. So roughly we accepted a 3D CRT plan compared to the VMAT plan, because though it is a slightly less coverage, but less dose to the bowel, gonads, femoral head. Few slides about the retroperitoneal sarcoma. CTV, GTV plus 1.5 centimeter. ITV can be used as a CTV. PTV with CBCT, you can go for 0.5 mm a centimeter, or without CBCT, you can go for the till 1.2 to 1.5 centimeter. So edit your CTV from the bone 0, bowel and air cavity, you can go inside the 0.5 mm, renal hepatic intercept 2 mm, skin surface 3.5 mm, inferiorly, if it is inguinal canal is there, go 3 centimeter distally. So there are two things. If your motion management system is there, if you are going to retroperitoneal sarcoma, if you are taking the 4D motion, you can give less margin. If 4D motion is not accessed, you have to give 2 to 2.5 centimeters craniocaudal and 1.5 to 2 centimeter radial direction. And PTV, if no IGRT, 1 to 1.5 centimeter, if IGRT 0.5 centimeter. If your motion is taken in the part, you can decrease the CTV expansion to the 1.5 centimeter, and same PTV things we can follow. If it is your things, the tumor is below pelvic brim, so say we can decrease your you can decrease the dose to 1.5, CT margin to 1.5 centimeter, but the PTV margin will be same, and 0.5 mm for the IGRT, and 0.5 centimeter for IGRT, and 1 to 1.5 no IGRT. Remember, you have to edit from the air, bone, organ, deep fossa, external skin, abort structures. You have to how much decrease, how much you want to crop it. It is given bowel and air cavity, go for 0.5 mm inside the bowel, and under the skin surface 3 to 0.5 according to the institutional practice. Simulation oral contrast is optional. Intravenous contrast is optional. 4D motion is strongly recommended. Usually 50.2 to 50.4 gray, 1.8 gray fraction, or 50 gray.
Someone is calling.
To IMRT, preferred unless organ dose constant target coverage can be achieved with 3D confronting, or you can go for a proton or photon. So these are the retroperitoneal sarcoma areas planning systems. Try to decrease the dose to the organ structure. So if suppose after giving the CTV, you can see here you have to decrease the, you can go your CTV inside the bowel around 0.5 centimeter and decrease the dose around the bone area. You can go to 0 mm, but don't corrupt exactly at bowel level. At least go 0.5 mm inside. This is the retroperitoneal sarcoma, and these are the various dose constant levels. I'm not going to one by one detail. You can follow this guideline, and these are the my testicles, rectum, bladder, perineum. This is the things we have to confirm. So when you are treating a pediatric person consideration, you have to ask your orthopedician or radiologist what are the growth plates. These are the joint space and growth plates. So you have to identify where the growth plates. So these are the growth plates. I have in pelvis areas. You have to contour. This is the again epiphysis. You have to contour around on this upper limb. These are the epiphysis upper limb. These are the epiphysis in the clavicle. You can see these are the clavicle epiphysis. And so how will you help these things? Suppose if you can divert your beam. Suppose this person, you can go this area treatment, you can divert, no need to APPA, you can divert beam around the non-epiphyseal areas, so that there will be no growth disturbance. There is a good table here. If there is 0 to 2 year, you can I will tell you these things. If suppose you are the chest wall sarcoma you are treating, people think that I will try to go with IMRT or VMAT, I will decrease the dose to the spinal cord bone drastically. Never do that. You have to treat whole the vertebra. How much dose gradient you can follow? So if it is 0 to 2 years, less 3 gray variation you can do. 2 to 6 years, 5 gray variation. 6 to pubertal acceleration phase, 5 gray variation. But after pubertal, all gradients are acceptable. So don't, this is the right side is wrong. So sudden dose fall is not advisable. So if the dose variations across the vertebra should be follow the age criteria, and usually 3 to 5 gray variations should be there. Toxicity, you know, the patient can go for the skin toxicity starting from the itchy to sore, desquamation and all things in the acute phase. So you can use moisturizing skin, moisturizer cream, ask them to pat the skin rather than rubbing. Use baby soaps. You can remove hair in treated area. You can use electric razor, but avoid sun exposure, swimming area, and follow instructions during radiotherapy. Handling side effects, most of the lymphedema, arthritis, fracture, fibrosis, fertility, second cancer, these things has to be answered properly, and keep in mind when we are contouring. Lymphedema, if patient developed lymphedema, so you have to do the physiotherapy regularly. These stockings is a very good thing. Ask the patient to wear the stockings to prevent the edema, and these stockings are the 200 to 300 rupees. It will prevent the edema. Regular wearing is prevent edema, and as well as the DVT, long-standing venous thrombosis, all things it can avoid by simple stockings. In summary, refer the articles, go through the e-contour, try to decrease the morbidity. For immobilization, try various positions till it suits you and patients. Review your contour of your other colleagues, talk to the pathologist and surgeons, and multidisciplinary approach. I pray God to reduce the sufferings of the patients and the attendants, and dedicated to the all things to my patients and caregivers. You can go through my website where all links are there, like good links like PubMed, ISTRO, Astro, QXMD, Lancet Oncology. When this, you can, these are hyperlinked. You can directly click here, all important websites, what are the regular user for a radiation oncologist. It is here. You directly can go through it, and you can go through my oncology cartoons, YouTube channels for the various target delineation guidelines. And thank you, my all teachers who has taught me the things. And thank you, the AHRCC or now the AGPIC for the giving the opportunity. And I congratulate you all and thanking and completing my presentation.
Thank you,
Thank you,
Kanhu, for your nice presentation. I think there is some questions in chat box. Dr. Durga can go through. Yes, sir. Yes, sir. I'll go all the questions one by one. Let's see. The first question: is pre-op RT standard of care recently for all extremities sarcoma cases? I think Dr. Sadendra may answer this question.
Yes, pre-op RT is not the standard of care till that for all sarcomas. It depends upon the histopathology also, and pre-op RT, though it is as we have explained, the study varies. Pre-op RT or post-op RT depends, but definitely pre-op RT is preferred over post-op RT. Slightly advantage of pre-op RT over post-op RT, but again there is no overall survival advantage, but it is preferred. If it is stage 2 and 3, it is preferred.
I think Dr. Ali KPR. Okay, but I've got the answer. Okay, the next question is about any role of adjuvant in MPNST.
In MPNST, it is MPNST mostly. It is most of the time it is part of the syndrome actually, neurofibromatosis 1, and it is a very aggressive tumor. So definitely in MPNST there is role of adjuvant therapy. Adjuvant therapy in form of radiotherapy also. Also we can try chemotherapy, because most of the cases in MPNST they present with finally they go for present with distant metastasis. So along with radiotherapy and surgery and radiotherapy, definitely surgery is the gold standard. But after surgery in MPNST cases, we should always consider adjuvant chemotherapy also. And in metastatic setting, if it is metastasis, then we can go for targeted therapy also, like trabectedin. But definitely there is role of adjuvant therapy and adjuvant chemotherapy specifically. And the chemotherapy of choice is again doxorubicin along with hypospan.
On the sarcoma cases, we need a multidisciplinary discussion about the histology and these things. So
all the sarcoma cases they need multidisciplinary.
All the sarcoma cases need multidisciplinary discussion. Okay, we'll move to the next question. Is there a management difference of radiation-induced sarcoma?
Radiation-induced sarcoma, by definition, like previously, it is like sarcoma developing in the radiation field, previously radiated field. Also, it should be like after 3 years of radiation exposure. But now they have memory slowing latent people. They have changed this to 6 months. So this radiation-induced sarcomas, they are aggressive, and the management doesn't change. It is just like other soft tissue sarcomas also. But the thing is, radiation dose is compromised. We have to take into consideration the duration from the development of the sarcoma. Like if it is a longer duration, we can go for full dose of radiotherapy. Definitely taking into consideration the normal tissue toxicity. But it is of less duration, like 1 year they developed sarcoma. New sarcoma, then you have to go for adjuvant chemotherapy in that case. But chemotherapy, it is less responsive radiation to radiation-induced sarcomas. But chemotherapy is an option again in just like in MPNST. All the high-grade sarcomas, like high-risk sarcomas, those are like there is role of chemotherapy also.
Sir, one more question we have received. I have put it on.
Hello.
Yeah.
Hello.
Hello.
Yes. Yes, sir. I think we'll move to the next question. I think this question is answered. Now the question from Dr. Soumyaranjan Misra. As sarcoma is radiobiologically equivalent to breast and rectum, and drilling surgery is the major discussion while considering neoadjuvant RT, what is the role of hypofractionated RT in sarcoma?
There is definitely a role of hypofractionation RT. Actually, there is no randomized trial proving the role of hypofractionation in radiotherapy in sarcoma. But people have tried, many single issue studies are there. They have tried like 25 grain 5 fraction, 42.5 grain just as in breast in 15 fraction. Also, people have tried 30 grain 5 fractions also with similar results, similar local difference, and like overall there is again no survival advantage, but there is local recurrence is same as in conventional fractionation. Also, the toxicity profile is same, but it will take time to find out the lead toxicities and like lead toxicities with this hyperfractionation. Maybe it is more or less. You have to find out. It is not like it will take time. More randomized control trials are needed for this.
Sir,
But we
randomized
can
control
try,
trials are-
definitely try.
Yes,
Whatever trials are there right now, they are single institution studies, no randomized control trials.
I think the minimum dose required should be at least 25 grain 5 fractions. Less than
25
that
grain
is
5.
the minimum requirement. So it needs a further evaluation. Okay. I think next we'll go to the next question. In case of inoperable head and neck sarcoma planned for definitive RT, should we follow an adaptive approach considering OAR constraints? I think this
This
question.
approach actually it is not defined in case of sarcoma. In carcinoma, people have tried this, but definitely when there is like loss of weight or something decreasing tumor size, we can go for adaptive radiotherapy. But no one can prevent you. It is always advisable also, but there is no study.
Kanhu sir, can you just elaborate something on this?
Yeah. So in head and neck cancers, definitive RT is not a good approach. So better to go for a surgery followed by radiation. Should you follow adaptive approach considering OAR constants? When there is a radical approach, adaptive radiotherapy, okay. But I don't think sarcoma is so it is a radio resistant. You cannot regress like squamous cell carcinoma so easily. So surgery followed by radiation is the best and adaptive approach if you can do, but I don't think there is a need.
The next question will be, what is an ideal CTV margin should follow in case of head and neck suppression sarcoma?
So ideal CTV margin for head and neck cancer 0.5 to 1 centimeter. I not like 4 centimeter above and natural way of spread, not like 4 centimeter longitudinal in the extremity sarcomas. Same thing in the mediastinum also. So not like that 4 centimeter, 1 to 1.5 or 0.5 to 1 centimeter.
Okay, sir. The next question is, in pediatrics during surgery, there is a role of.
In pediatric, if there is a extracorporeal RT, you can plan, but extracorporeal RT, it is easy to plan, and when there is a limb salvage surgery you are planning, it is a good option.
Yes, good option, but mostly used for bone tumors, not for soft tissue sarcomas. So the next question will be, what is the margin in mediastinum sarcoma in adjuvant setting?
Mediastinal sarcoma margin same only around 0.5 to 1 centimeter, not like longitudinal extremity.
Extremity, sir.
Head and neck mediastinal almost same only, like retroperitoneal sarcomas.
So the next question is, how we can follow up the patient after the definitive RT in unresectable sarcoma?
In definitive RT setting, follow.
Yes.
Okay, so you have to see regularly 6 weeks and 3 months. We see the 6 weeks at least. We see the operability. If definitive setting, you see the operability. If it is operable, you have to go for the surgery. And if it is not operable, then we have to go for chemotherapy. Definitive setting, it is not a radical approach.
So the next question will be, what is the pre-op RT dose in head and neck sarcoma? I think it will remain the same, sir.
In
Pre-op RT dose in head and neck sarcoma?
In head and neck sarcoma, hello.
Yes.
In head and neck sarcoma, the pre-op RT is preferable. Actually, it is the dose is still the same. It is 50 gray only, and pre-op RT is preferred in head and neck because there are many important structures. Surgery may be morbid. So pre-op is preferred in head and neck carcinoma, and the same Canadian trial, O'Sullivan et al. Also they have one study. So in head and neck also pre-op is preferred over direct in high risk cases, like mostly in pre-op head and neck cases, pre-op is preferred, and the dose is still 50 grams.
The next question, in mediastinal sarcoma, how much CT margin be allowed if it is going inside the heart? Should it be cropped completely? I think Kanhu sir may elaborate on this thing. In mediastinal sarcoma, how much CT margin be allowed if it is going inside heart? Should it be cropped completely?
So 0.5 centimeter inside the lungs, crop from the bone is 0. These are the very rare situations where we can go ahead, but we don't need to give like extremity margins.
So the next question is, what should be the minimum longitudinal margin?
Durga, Kanhu, yes, I would like to add to that. Actually, we are now treating a patient of mediastinal sarcoma. These are all individual cases where you have to see the extent of resection and you know, the anatomy, and then you decide. And minimum margin should be given, as you said, 0.5 centimeters. So 0.5, we have also given 0.5 centimeters, and we have just begun last week. So let's see, but these situations you need to give minimum margins.
You have to spare the lungs mainly.
Yes, yes. Please carry on, Durga.
Thank you. The next question is, what should be the minimum longitudinal margin you should take if the lesion is near a joint?
So if there is a no joint cavity involvement, you can stop nearby joint cavity. You no need to go for 4 centimeter margin or something. So yeah, joint cavity is not involved. We can cut up the near the joint cavity, but you have to see properly how much it is going. Have to properly evaluate.
But when a muscle or something, a sarcoma arising from a muscle that traverses beyond the joint, then we should take how we should crop the longitudinal distance or not?
Question please.
Sir, if some muscle is crossing over a joint,
Okay.
going beyond the joint to insert in beyond the joint, then if the sarcoma is arising from that muscle, should it take the crop down the CTV margin so as to avoid the joint? When the muscle is crossing beyond the joint, like involved muscle is crossing beyond the joint or the surface, then
Dr. Durga,
yes, ma'am.
I think it's over. Question and answer,
So many questions are coming. Another 3-4 questions are there.
Oh no, we have to conclude now. Dr. Rashmi, hello.
Yes,
Yeah,
ma'am. Yes.
good evening. Yeah, you want to give some suggestions or feedbacks?
Yes, ma'am. Yes, ma'am. Thank you so much. So
Yeah.
it's a very nice starting, ma'am. Am I audible, ma'am?
You are audible.
Yes, ma'am. So I want to just give 2-3 inputs. First is that I want to say that as pre-op RT is preferred, but in the most of the center we are giving the post-op radiation. Pre-op RT we are giving in certain situations when there is a large tumor, surgeons are not clear of their margins and something like that. But most of the cases pre-op RT is preferred. Still the trial says that pre-op RT is preferred. So first thing. Second thing about the extracorporeal radiation for the bone tumors. So it's a very useful tool in our Max Hospital. We are regularly doing. Our ortho-onco surgeon, Dr. Vivek Verma, is there. So it's a very sophisticated way of limbs, artificial limb or any prosthesis. So it will give you a complete prosthesis in the limb. So ECRT is a very important tool for the bone tumors, but it has certain indications that the bone should be intact, there should be no fractures, there should not be any infection. Third thing I want to add on is that about the margins, that our surgeons at Max, they are not taking the margin of 4-5 centimeter like previous studies. So there are so many trials, and we have discussed with our surgeons, they are taking maximum 2 to 3 centimeter margin. So there are so many RTOG trials, Berry et al. Published in 2022, even in high grade more than 5 centimeter tumor. They are taking 2 to 3 centimeter craniocaudal margin, but what they found is that the radial margin is very important, that they are taking it's 2 to 2.5 centimeter. So it's an investigational process, but in our institution, our surgeons are taking only 2 to 3 centimeter margins craniocaudally. So we are just trying to reduce, but it is individual patient basis we are doing to that. And fourth thing is that in mediastinal lymph sarcoma, I have just a 26-year-old boy of sarcoma mediastinum, but the hard doses that 2 times one person is asking. Am I audible, ma'am?
Yes, ma'am, you are
Hello.
audible. Please,
Yes.
Yes,
please go
ma'am.
ahead.
So in mediastinal sarcoma, it's very difficult to achieve because we have to at least go up to 50-54 gray, because the heart, if the tumor is just our PTV CTV is coming over the heart, that is the most crucial position, and especially the left ventricle is coming and left anterior descending artery is coming. So we have to take care of that. It's you have to explain the patient that you have to repeat the echo, 2D echo like that, or there might be a risk of cardiovascular event in the future. We cannot avoid it. Only 5 mm margin we are giving on the heart, but still LAD and left ventricle we are getting at least 50-54 gray. How much VMAT, IMRT, Rapidac, whatever you are going. So you have to explain the patient about the risk versus benefit ratio. And thank you, ma'am. It was a wonderful session. Wonderful session.
Thanks, Rashmi.
Okay, so now I would like to invite Dr. Lucy for word of thanks. Please, ma'am.
Thank you very much. This is my proud privilege to deliver the vote of thanks. We have kick-started our monthly oncology seminars from this month onwards. First, I would like to thank our senior teachers and our advisory committee, Professor Dr. K.B. Das and Professor Dr. UN Panda, who have spent their valuable time with us and have kept patiently, they have participated in the entire seminar. Our Professor Dr. S.N. Senapati, President-elect AORI, our HOD, who has also given the welcome address and has participated actively in today's seminar. Our President AORI State Chapter, Professor Dr. Niharika Panda, and Head of Department Radiation Oncology, our Secretary, Dr. Sanjukta Padi, who has taken all efforts in organizing today's session. And our speakers today were Dr. Sarendra Parida from our institute. He is assistant professor in our institute, Acharya Harihar Postgraduate Institute of Cancer, and Dr. Kanhu Charan Patra, as we all know, he's senior consultant in Mahatma Gandhi Vizag, needs no introduction. Our moderators, Dr. Durga Prasad Sahu, he's assistant professor here in our institute, and Dr. Sulagna Mahanti. She also moderated the session with Dr. Durga Prasad Sahu. Dr. Sulagna Mahanti is assistant professor. So we had more than 100 delegates from all over the countries. We had a couple of international delegates also. So it has been our opportunity. All other members who have joined in and logged in today's session, I would like to thank on behalf of our head of department and our department of radiation oncology. I would like to thank all of them, and our ClearNet virtual platform for scientific session and digital platform, who has given us an opportunity for digital participation. Thank you very much. Over to our secretary, Madam Dr. Sanjukta Pal.
Hello. Hello, Sanjukta.
Yes, sir. Yes, sir. Yes, sir.
Just I will take 1 minute
Yes,
before
sir.
you close.
Please, sir. Please.
It's a really, I'm so impressed, and it's a really nice endeavor by our state chapter radiation oncology association. Thanks to the team, very much appreciable, and this should be continued as you said. My one thing I suggest, you program the speakers in such a way, so it should not be, just like a book teaching, right? It's a very informative, and more time you should spare for the discussion as you had today. It's a nice discussion. Okay, this is, again, I thank for the team. I thank the team so much, and carry on, continue, maintain it. Thank you.
With your blessing, sir. Sir, my special thank to our Secretary General, Dr. Srinivasan. This is kindly kind enough to present in our seminar. And sir, Senapati sir, would like to say something? Concluding remarks?
Yeah, it's an excellent presentation and also good starting. And I am happy that so many known faces, particularly towards the country, particularly Dr. Rashmi, she is here. But do you know that Rashmi also belongs to Odisha? So her heart is also partly in Odisha. And also she nicely deliberated that very key points. And particularly the presentation of both the speakers are definitely good and also up to the standard. And most of the people who are here, definitely I think they will be benefited with this such type of presentation. And we invite the suggestion from all of you that how best also we can improve this program. And this is our ongoing program and will continue. And any suggestions? I think you can also, Sanjita can give a email ID so that we can also more and more interact and also get more feedback so that we can improve ourselves. Okay.
Sir, and I'm putting my mail ID in the chat box. Anyone who want to give, please give your inputs and feedback so that we can improve in future. And next month we are going to have a lung cancer.
Hello.
So please do join. And the date and the links will be shared at proper time. And sir, shall we conclude?
Yeah. And special thanks to Kanhu.
Momita,
Kanhu.
over to you.
Okay.
Thank you so much, Momita, for your kind presence.
Thank you so much to all of you, and thank you for extending us the opportunity to host the session, and I hope you had a seamless experience. So with all due permission, I'm closing the session for today.
Just a minute, Momita, I am just putting my mail ID.
Yeah, sure, ma'am.
After that, you can conclude. Huh?
Sure.
Yeah, it's over.
Okay.
Yeah, you can. Yeah.
So with all due permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much to all of you. Good night and take care.